We all know about.
At least, we know what the choroid is doing in all these diseases. So over that time, what was realized that, vitreous findings we were not able to visualize properly with the EDI. So over the time, it was realized that, okay, you need some better tool where you can have little bit of the vitreous visualization along with the, the posterior things that you can see. So with the help of little longer wavelength, 1050, you could visualize beautifully vitreous, and further you can go back. You can see the junction little pretty well, and apart from that, you can see halus, atlas, and the choriocapillary as well. So what happened was, after that, normal choroidal thickness that we need to define if we really want to show that, what is the abnormality, whether it's thick or thin. So the problem is there. The range is pretty high. If you see 191.5 to 354, there are reasons for it, because choroid is a variable structure. It is not, neural structure like inner retina. It is a structure which has vessels, and vessels, they change as per, even within the day. They change as per the advancing age. They change as per the region. They change as the myopia progresses. So that is the reason that, there is a lot of variability in especially subfoveal choroidal thickness. So over the time when we were doing the manual segmentation with the manual caliper, over the time it was realized that, it's quite cumbersome. You might be little different, in checking these parameters. So automated segmentation came in, binarization technique came in. Then over the time it was realized, okay, it's better to have a little volume check so that you can have more information. Further, you have a choroidal vascularity index. It was shown that, this index seems to do little better in terms of the variability if you compare with the choroidal thickness alone. So, and for imaging, choroidal contour, 3D reconstruction, OCT has been well covered. So what things we have learned after choroidal imaging? So this is the entity now after choroidal imaging. Has been quite well known to all of us that, there are some situations where choroid becomes really thin. You can't actually see the choroid, and but your RP is pretty healthy. So in these cases, you can prognosticate that these patients, they do well because RP is still healthy. They are not going to go in the form of GA. In terms of myopia, less choroidal thickness, quite okay. But with the each diopter of myopia, you have less choroidal thickness. But if you see these patients, they do not do bad in terms of the visual acuity. So you do not have the real correlation that what kind of choroidal thickness you can predict the visual acuity. That doesn't happen. Another concept which was cleared, in terms of the posterior segment evaluation with SSOCT, which is the dome-shaped maculopathy. It was known and considered that basically there was a sagging of the sclera all around. So that was the concept. But over the time, it was realized that basically it's the middle sclera which gets thickened, and because of that, there is a squeezing kind of effect that you have in the central choroidal vessels, and that gives this fluid. So you do not need to treat this fluid basically. CSCs, it has choroidal thickness had helped a lot in terms how the pathogenesis is, how the treatment is, and how you follow these patients. For example, in this particular patient, if you treat this patient with a focal laser, you see there is no change, hardly any change in the choroidal thickness. However, if you treat this patient with PDT, you can see the choroidal thickness going down. So we learned that focal laser and the PDT, they are quite different treatment options, and actually PDT does a much better job if you treat these patients over the time with PDT. Again, another disease, which is quite helped with the help of the choroidal imaging. For example, if you see this particular patient, right eye and the left eye, in the initial visit, quite thick choroid. You can't even see the posterior choroidoscleral boundary. But once you treat them for the 3 days, and then the choroidal thickness comes down. In the other eye, again, choroidal thickness comes down. And then look at the left eye. Look at the left eye after 3 weeks. 3 weeks, there is a huge recurrence. You see the big NSD. But important point to learn here is the right eye. If you see the right eye, there was a thickness which was down previous visit. Now the thickness is up. So now we have learned that these kind of cases, they are ready for the recurrence. So you can actually plan the treatment a little bit ahead so that again recurrences would not do harm for the visual acuity. Again, pachychoroid spectrum, we know the importance of the choroid in these cases, that all the larger vessels, they compress the choriocapillaries, and previously we were not knowing all those tiny higher, we were writing all these cases RP pigmentation, RP atrophy, RP changes, but they are not them. So basically, it's a kind of a spectrum which starts from the pachychoroid pigment epitheliopathy, then leading to CSCR, leading to type 1 neovascularization, leading to PCV. So apart from this, intraocular tumors actually, this fundus photo quite helpful in intraocular tumors, but still, because the technology is there, so you can actually differentiate some of the conditions. For example, melanoma, if you see quite a smooth kind of structure, while if you see in the hemangioma, you have hyporeflective spaces, which actually detonates the blood vessels. For example, metastasis, you see a lumpy, bumpy RP. You see that kind of RP here also, but there is a difference. If you see, there's a subtle lumpy, bumpy RP, where you have here is a C-sick kind of appearance. And this particular case, if you would like to differentiate, sclerochoroidal calcification, the choroid is not doing anything. It's basically the sclera which is just pinching the choroid and making this undulated. So these are subtle differences that you can find out. Osteoma, easy to diagnose, but still, choroidal imaging can tell you there are some intralesional horizontal lines that you can see there. Now you would ask me a question that why I'm not talking about the AMD, more common conditions, DR, retinal dystrophies. We are not clear. AMD itself is not clear. AMD is going through a vast change in terms of the definition, in terms of the way we design it, because there are too many components: PCV, drusen, soft drusens, pachydrasens, hard drusens. So what is going to happen in the near future is, even before I go further, there's a caveat. For example, if you see, it's not very easy to really find the boundary of the choroidal scleral junction in all these cases. So there are some cases where you have this kind of bend. So what kind of boundary you would choose to really check the choroidal thickness? So that's a question that we need to answer. Probably this is a suprachoroidal space that we are dealing with. So not in all the cases, but if this comes into play, then all the actually parameters would go haywire. So this we need to check. So that is why, a beautiful paper came in which says, why don't we just, divide into three? For example, the inner one would call as a vascular CT. The middle one we call it a stromal CT, and the outer one is a total CT. So at least you have an idea, that what kind of a structure thickness we are talking about. And at the end, AMD definition, as I said, is going to change again, and the person who is behind it again is paid. So if you see the paper which was published in December 2018, what he says is, you might not need a fundus photograph in near future. What happens is, for example, let's just look at this left side picture. This is the healthy eye, left eye, color photograph, where you have a pachydrasen. On the other eye of the pachydrasen, you have a PCV, full-fledged PCV, the huge, thick choroid that you see. So pachydrasens are associated with the thick choroid. In the middle one, if you see, there are soft drusens. Soft drusen, there is in the one eye, and the other eye already you have the type 2 neovascularization going in. Another one, the pseudodrusens. Pseudodrusens, you have a rep lesion there in the other eye, and the other eye you have a pseudodrusens. So what Spade says that over the time, you might not see these fundus photographs. You just look at the location where exactly the material is deposited, whether above RP, below RP, and just look at the choroid. If you have a thick choroid, designate it. It is a pachydrasen. If you have a thin choroid, designate it. It is a pseudodrusen. It has a more propensity to go to the geographic atrophy. And if we have a normal choroid, it is a soft drusen. So we might see a little bit change in the classification over the time when we approach 2020. So to summarize, choroidal thickness, highly variable according to the disease, age, and axial length. Choroidal volume shows similar information as CT. CVI has a little low variability. ANFOS imaging has improved vessel detection. OCTA gives good information about type 1 CNVM. Another change, now we call everything as an M and V rather than C and V. AMD might be redefined with choroidal thickness. Thank you.